Thank you so much. I am really excited about this. We're going into our after show. John, if you have a few moments, we may have a few questions from patients who are on, and Dr. John might have a few thoughts as well. We have quite a few folks with PAD on the line. You may have even a question for them that they might be able to speak on. But happy to open up the floor.
I'll just say, if you don't mind, I'd like the idea of using devices like these that are, it sounds like pretty simple, but yet provide a wealth of information. I saw on your website, you guys offer venous testing as well. I mean, so like the machine will, and I hate to boil it down to return on the investment, but the machine will pay for itself because when I order an ABI on somebody, and yes, over 50 with risk factors, all you really have to say is that they have pain in their legs with those risk factors, and it gets covered. Now, it's a little bit more dicey in a younger person, but you can, assuming they have an abnormal vascular exam or something. So it's not really hard to get the order in and the insurance companies to pay for the ABI. And so I think it's a wonderful thing that you guys are doing, trying to educate more providers and put good technology in their hands.
Well, I appreciate it. On that topic, it is interesting also, though, to have patients kind of accurately represent what they're experiencing in their legs. I have witnessed firsthand with patients where I can see the skin is almost like rice paper. They have little wounds, ulcers. And when asked if they're experiencing leg pain, the big guy said no. And we said, okay, but if we asked your mother if she was experiencing what you're experiencing, what would she say? And he'd say, hurts like hell. and so getting the right people, getting the people to sort of represent what they're experiencing can be challenging at times.
It is. For example, my dad, he's actually experiencing what most people 24/7 would consider level 6 in pain. And he's telling the doctor, he goes to the orthopedic doctor and says, oh, it's a level 3 and I have it all the time. And the doctor was like, yeah, fine, go home, suck it up. You're great. No problem. And I was like, you told him you have a level 3? I mean, in what world? He has a very high pain tolerance, but he's a former military guy.
Yeah.
And so his level 3 is actually our level 6.
Yeah. And it's interesting. That's why I always tell patients, bring a quote consultant with you to the visit if you can, because they're going to call you out. I had a gentleman that was referred to me. He had an abnormal ABI and he wasn't particularly symptomatic. And I said, well, do you know why you're here? And he's like, well, yeah, he points to his wife. She made me come in. I was like, okay.
Right.
But it's the same thing. It's like pulling teeth. They're like, are you having any symptoms? No.
Yes.
Okay. Right. Well, tell me what you do. And then it's like, okay, you tease it out. But if I'm a primary care doc, I'm moving on. Like, okay, your legs don't bother you anymore. All right, moving on. Next problem. And so I understand how difficult it is for PCPs to deal with this.
So to that extent, sometimes what we encourage is to screen at-risk patients. A little easier to work into the clinical workflow. You can have a medical assistant do that as part of that pre-physician face-to-face meeting. And if you have that abnormal ABI that you did, now you have something to work with the patient to sort of show also that there's evidence that there is something obstructing blood flow, and to talk about that.
And we have a message on YouTube from Marcia Burr. She's wondering how to get these devices in the hands of rural doctors and communities that don't have access to more specialized facilities.
Love the question. And in fact, if there's a specific community of interest, that's just, we have to do the work to get there. But in today's world and the way we can communicate, that is much easier than 20 plus years ago when we started. So would love to be able to collaborate more effectively in rural communities. I really do think that's an important part of the future role of primary care.
And I think that's something that we can even put a poll in our groups and find out who has access to primary care physicians and who who doesn't? Who has to drive? We have a couple patients that have to drive at least 45 minutes to an hour to get to someone. And many of them have to rely upon friends because they don't even have cars themselves.
Sure.
And so that's tough. We do have Douglas that has a question, I believe, if he is still on somewhere. Douglas, go ahead and unmute.
Yeah, my question is for both Johns. What is one of the toughest things you run into today in getting this information out there, and with the insurance and with your primary? What is one of the toughest things you've run into today?
John, you want to take that?
Sure. I'd say, so we're talking about leg disease specifically. And I think one of the challenges is getting people to appreciate it as a worthwhile and important and a dangerous condition when you talk about a leg attack versus a heart attack or a brain attack. So a stroke or a brain attack, people understand it, don't want that to happen. Heart attacks, I think everybody appreciates. But when you talk about a blockage in your leg, I think people, they discount the impact. And so that's one of the challenges, is to achieve that sort of priority and focus on leg disease.
And it's interesting, and to Dr. John, is 3 in 5 people who suffer a heart attack, I think I saw, have PAD. And how much easier would your job be to prevent heart attacks if you could get more patients diagnosed sooner with PAD?
Well, I mean, a lot easier. And then the thing that I struggle with is, and we've talked about this before, it's lack of awareness. PAD is not a quote, and I'm not discounting any, cancer movement or anything, but it's not a sexy disease.
Right.
To your point, there's a handful of cancers that are more deadly than PAD, but patients don't recognize it. Patients often don't, when they see, a black dot on the tip of their toe, it doesn't set alarm bells off but you find a lump somewhere that sets alarm bells off. And I think, I don't know how we fix that, but we're certainly trying to do our best. To answer Douglas's question, to get an ABI or any vascular tests is very easy. What we're running into trouble now is with insurance companies covering the angiograms that I do, and they're often like asking me to say if I'm going to put a stent in or what am I going to do ahead of time before I've even kind of laid out the anatomy, so to speak, and got an understanding of what the blood flow is. And I think that is part and parcel to what has happened over the last year or so with the overuse or the perceived overuse, but there is overuse of some of these high payment, highly reimbursed devices that have put a black eye on what we do, frankly. I mean, it's the old adage, a few bad apples spoil the whole bunch.
I know, it's even more interesting though about this. And I just spoke at the Vascular Leaders Forum through Viva in Washington, D.C. on exactly that topic. In that patients, when I polled them after reading a New York Times article that led to a big discussion about the overutilization of devices for revascularization or opening up the arteries in minimally invasive ways, the patients rightly said, well, yeah, maybe there is some of that, but why aren't we talking about the overuse of amputation as frontline treatment, with more than 60% of all amputations being performed without even an attempt, following society guidelines, to attempt to restore inline flow? And even more, and I know John Romans is going to love this, 90% of those, not even a vascular assessment in the year prior, with devices like this readily available for every doctor to have inside their clinic. Just blows my mind why the media is covering the other.
It's hard not to just sort of jump on a plane and go straight to Washington, D.C. On this topic, because it's just, this is avoidable. We spend a lot of our time now with all the major insurance companies. I will say what's exciting from their perspective is they have all embraced our technology. So we actually a client base for biomedics are the insurance companies directly, who then deploy technology to their employed or contracted physicians. And that's something that's growing, and I think that will help to continue this access or democratization to early studies.
That's good.
But
We have a question.
but-
Go ahead.
Please. No,
No,
please.
I was just gonna say real quick, in my opinion, part of the issue too, with lack of awareness, is that the patients that get peripheral arterial disease are often on the fringe of kind of society, so to speak. They're underserved or more urban, like statistically speaking, lower socioeconomic. There's this perception that, quote, they did this to themselves, they smoked or whatever. I mean, I know of physicians that won't treat patients who have PAD because they still smoke. And that, like, if you have that bias going into this specialty and this disease pathology, I understand why it's not on the radar of, it's not, I have a slide listing all these famous people that have breast cancer. Everyone knows that they had, I say, what do all these people have in common? Well, they all have breast cancer. Everybody knows it, but there's just no appetite, in my opinion, to take on PAD in like the national spotlight or media for that matter.
But even if, and this is what's interesting, with more than 50% of people in the US, according to the American Diabetes Association, more than 50% of US adults having type 2 diabetes, you would think that it would open up people's eyes to the conversation about PAD if doctors would only call it PAD. ABC came out with a fantastic, very powerful documentary called Severed. The problem with it was diabetes, 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 poor circulation due to diabetes. And even the reporter told me in an interview we did, actually, you and I did, John, he told us that, well, we need it to be called diabetes because people care about diabetes. They don't care about PAD. And where we're finding a disconnect is when patients go online to look up diabetes and doctors are telling them you're getting your leg cut off because of diabetes. They can't go online to search for potential options to treat those blocked arteries. So they settle for amputation, not knowing something else might be available. So I think we need better education to say it's poor circulation, it's known as PAD, and there is something we can do about it.
And to sort of shine light on where there's some favorable trends, the American Diabetes Association, in their most recent clinical conference, came out with a strong recommendation for PAD screening in patients with diabetes. So that is progress. And there's another opportunity that's here, especially in the Medicare space. Within the Medicare Advantage population, there's been some criticism that chronic conditions are being identified but not subsequently treated. And so with respect to making sure the insurance companies continue to support appropriate care with minimizing prior authorizations, for instance, and providing reimbursement to physicians who are treating PAD, that there is now a strong push to make sure that those people identified with PAD are receiving care. And the insurance companies need to show to CMS that they are funding subsequent care for those with PAD.
But even if you just look at it from a dollars and cents standpoint, if you can, I mean, I can't remember the number, but it's tens of billions of dollars that are spent on diabetic complications, and the majority of those are vascular. So if you screen these patients and get them on the right medical path and lifestyle path, you're preventing and you're saving the healthcare system a lot of money.
This really is about as strong an economic decision as well. So this should happen.
It's interesting. Did you see John Squared, the Dr. David Armstrong, who's a podiatrist out of Keck School of Medicine at USC in Southern California? He said that, and I can't quote the exact numbers, but he said now we're at a point where diabetic complications that are vascular are literally costing the healthcare system more money than now all cancers combined.
Yeah, I have some material on that which I can pass along, and as a podiatrist, it's interesting. There was Peter Sheehan, who's since passed, was a diabetic specialist, and was early on talking about it isn't so much about blood sugar management. It is about the risks of a major cardiovascular event that is what people need to be thinking about with diabetes. And in early conferences, I remember him just almost being laughed at. His father, believed in podiatry, by the way, was a runner and had his a foot injury that just wasn't getting fixed. And so he came across a podiatrist and really was enamored what they were able to do. And it was those people that introduced me, candidly, to podiatry. I didn't really understand what doctors of podiatric medicine, how they were different. But what I quickly realized is that when I go into my physical, I'm encouraged to take everything off my body except my socks. And with PAD, the first place we need to be looking at are the feet. And so podiatrists were just sort of a natural place to start in that primary care community to focus on PAD.
And we have a question from Regina. Regina, do you want to go ahead and unmute and you can ask your question?
Yeah, I have chronic venous disease and May Thurner's, and I've recently had 2 stents this year. And they've done multiple treatments on the vein issues. But they also said I have PAD, 50% blockage in my iliac. After I got the stents put in, my blood pressure, which I've always had high blood pressure, but my blood pressure went higher like 2 weeks after I had the stents put in, and I started wearing the compression socks all the time. I've done this, not wore the socks, measure my blood pressure, wore the socks, measure my blood pressure, sit down, lay down, everything. And just during the day, it still continues to be high. And they've changed my medicine, give me more medicine, one thing after another. And I still can't get the blood pressure under control. And I was curious if it could be related to the PAD in the iliac veins or iliac arteries.
Dr. John?
I would say highly unlikely. There is sometimes patients can have a complication with the opening the vein and then potentially disrupting the artery at the same time, which then creates a mechanism where the heart is working a little bit harder and the blood pressure goes up. But yeah, I mean, May Thurner and then so 2 separate highways of blood travel, one south, one north, and then the arterial blockage is unlikely to cause high blood pressure. In fact, sometimes they can cause a perceived low blood pressure because there's narrowing within the within the artery where the blood pressure is being managed. So I mean, it may be your body just kind of readjusting to changes in blood flow from the stents that presumably are now helping the symptoms that you have in the leg from a venous standpoint. But to my knowledge, I don't think there's any link between the narrowing you have in the iliac artery and your blood pressure.
Any critical questions she can ask her doctor based on what you've heard?
No, I mean, I would just, again, it's the old adage, like you have to, when someone has peripheral arterial disease, you've got to be looking for cardiovascular issues. And, so it's important to have a discussion about symptoms and risk factor modification. So antiplatelet use like aspirin and good measure, routine evaluation of cholesterol levels and if elevated treating and, making sure your blood sugar's under good control, don't smoke, things like that.
It was interesting. We had a patient that presented to the hospital just last week in Florida who had extraordinarily high blood pressure. And the only thing that came out of the being admitted to the hospital was they gave her medication to control the blood pressure and diagnosed her with PAD, and actually told her that the high blood pressure was due to undiagnosed severe PAD.
Well, that might be in the case if there's blockage in the kidney arteries that can cause high blood pressure.
Oh, interesting.
And so that technically is PAD, but you don't get high blood pressure from the PAD that you and I talk about on a weekly basis in the legs. You don't get high blood pressure from that.
And
just one follow-up with the caller is that do you have PAD and venous disease in the same leg? I was thinking through on
Virginia. Mm-hmm.
Yes. So the PAD though is just in the iliac arteries. They said that my arteries in my legs are good, just the veins are terrible. And they've been working on both legs, and my iliac, one was 90% compressed in the veins, one was 80%, and the vena cava was compressed. So the stent goes up into the vena cava. And after I got the stents, a lot of the symptoms that I was having with like migraines and stuff, a lot of that went away. But my legs still are not great. Really not much improvement at all. And the other thing is the blood pressure, and they've done the renal artery ultrasound. It looked fine. They sent me to the cardiologist. They've done a bunch of tests there. All those looked good, they said, and nobody has an answer for it. But it just spiked like this after I got the stents put in, and they did make sure that the blood was flowing good through the stents like 6 weeks later, and those were still good.
Yeah, I would just say it's extremely rare for patients to have narrowing in both veins and the IVC. So I'm a little, this is again my opinion, so it's not worth that, you can get a cup of coffee and that's about it with it. But it's extremely rare to have narrowing in both veins. So I'd question that diagnosis, but either way, it's what's done is done. The other issue is sometimes patients just have resistant hypertension that all of a sudden it just happens.
Yeah.
The nice thing about that, there are treatment options out there called renal denervation to help certain patients, pretty specific patient population, but that's something that potentially you could just discuss with your physician should your blood pressure not be able to be controlled over the next few months or so with changes in medications.
And Regina, I owe you an email. It's always good when you text me to let me know you send an email. I'm so sorry that it's taking me so long to get back to you, but we'll follow up, okay, today with you on that. Are there any other questions for John Squared before? I don't want to keep them all day.
I have
but
a quick one.
Douglas, sure.
Well, this sounds very exciting, and I was wondering, where do you see it going from here, and the possibilities of change in making a difference in saving lives and limbs, and making a difference between the hospitals, primary care, the little shops, everybody. And it just sounds so exciting. I was wondering where you thought we'd go from here.
Well, on the technology side, I can tell you what is inspiring me today is that you are taking the time to participate in a conversation like this. The Kim is leading. So I think that the work in engaging with patients is, in the end, going to be what's most exciting. We're working very hard to make this kind of technology to better understand this disease early in the primary care setting, but ultimately finding a way where we can do this in the home and work with patients directly so that you can advocate for the best care by being informed is what I think would be most exciting.
We already have people that actually are buying the pulse oximeters for the fingers and using it on their toes. And while Dr. John over here has talked about it, I think in our early days of the show, where it's okay to do that. It's not accurate, but if you do it every day and you have a consistent number, if that number changes, it could indicate something. But it sounds as though, which I'm excited about, that there could be something and I think there should be something such as we have a thermometer, right? And we have blood pressure cuffs for our arms. How easy would it be for the patient to then actually learn how to put that blood pressure cuff on their legs as well and be able to do it?
Yeah. I mean, I think that the only, in my mind, the only rationale for doing that would be in someone who's had a procedure and monitoring the durability of that procedure. Because sometimes
Love it.
we lose patients who, they get the procedure done, they feel great, and then we never see them again until like 3 years later when the artery's narrowed. And so that, I think, is a very value added thing. I have patients that check their blood pressure 3 times a day. They can do that. That's great. It does not help me clinically one bit. And we get ABIs on patients once a year. And it's the same thing, like, so from a cardiology standpoint, if someone had had a heart attack in the past or a stent 15, 20 years ago, they got a yearly stress test. We don't do that anymore. It's not cost effective. And patients have to tell us if their symptoms are back, and then that prompts us. And so, yes, if there's a clinical change, I think it would be value added. But until then, unless if it's just, free, it's free to the patient and they can, do it on their Apple Watch or something, that might be a benefit. But routine ABIs, probably unlikely.
John?
I think here, community-based collaboration is key. I think we've talked about screening programs that don't have connection to information or care, really just sort of creates dead ends. So to the extent that we're talking about having technology sort of used in the home by patients in a independent capacity, I think it has real shortcomings along the lines of what Dr. Phillips was just saying. To the extent, though, that we can get to the patients sooner, we're working through primary care and podiatric physicians to make that happen today. And there's a lot of work to do. So we're not in a position to take our eye off the ball until we feel like we have reached all the markets. And as your callers have mentioned, that includes the rural communities where, in many cases, this care is more desperately needed than in many major metropolitan areas. And as long as we're keeping those that have the knowledge, because care protocols will continue to change, as Dr. Phillips just mentioned, what was done just recently is no longer the same protocol. So we'll always want to make sure that we have the specialists collaborating with people who have access to patients, and then obviously the patients as well.
And we have Marcia again on our YouTube channel saying that Levy County, Florida, Levy County, Florida. So she hopes to see your device at a clinic there so that she can have access to it. And what's interesting about this partnership, and one of our goals, right, is I mentioned once during this program, but it's worth mentioning again, is to inspire other primary care physicians to adopt a technology. It may not be yours, but you know what? It is a great technology. You are in more than 1,200 sites across the U.S. You're well respected, with the technology. You said you've had more than 1 million readings, across the U.S. at these clinics. But we want to get more and more primary care. I don't know what it is, and maybe Dr. John could touch on this. I don't understand why we've had such a hard time in the vascular community shaking up the primary care industry to do this. And I know that they're already overworked. They have a lot on their plate. There's a lot going on, but everyone has a lot going on right now. And I've tried to get to talk to the primary care societies. There are multiple ones, and it's crickets. But I find that I'm not the only one, and I don't understand why. But yet here comes biomedics, and they're infiltrating. They're going one by one by one and literally saying, hey, just put this in your clinic. And they're succeeding.
Yeah, I mean, I've got to run event here, but I want to say one last thing. I think it's because they just have way too much on their plate already. In my opinion, and I'm not an expert on this, but I think there's a lot of nurse practitioners out there that I think are a little bit more willing to maybe spend the time with the patient and maybe dive into some of these kind of diseases that are often maybe overlooked. And so I think getting into nurse practitioner run clinics, obviously under supervision of a physician, that's probably a nice little sweet spot as well. Because let's be honest, we're not the physician. There's going to be a major physician shortage. There's already to get an MA. I mean, it's almost impossible to hire an MA to do the. I mean, it's just like there's a crisis here, a person power crisis, and so I think that's probably why you're running into some of these roadblocks. But
and before you go, and then John Romans, we have just a couple more questions for you. We have a special treat actually for Dr. John. So I want to turn the attention to Sunshine. Sunshine, you have a special treat for Dr. John. Give her a second.
What?
You have a special treat for Dr. John. You want to show him?
I think you
Sorry,
skipped
she
it.
got her audio off.
No,
Yes.
it froze up. Like it froze up. And like you said something like a short sentence. You started talking, and then
It just
nothing.
froze.
And then
So-
you were like, "You want to show him?" And I'm like, "I don't even know who you're talking to right now."
So Sunshine,
Hi,
you
Sunshine.
had a
How are
milestone this
you?
week.
I'm good. How are you?
I'm well. I saw your video. Kudos.
Yeah.
That's awesome.
Hold on. I'll show you again.
Oh, good.
Fantastic. This is such an amazing moment. She has been working so hard. I am incredibly proud of her. Look at this.
Can you see?
I can see. That's amazing because upwards of probably 40% of people who have a major amputation never walk again. So awesome. Kudos.
Thank you.
Sunshine, nice
It took a
job.
long time.
It
Hey.
did, but you kept on going and you're persevering.
Just like
Yeah.
our quote for the day, right? Don't put off, what you can do today till tomorrow. So good job. Well done.
Thank you.
And thank you for sharing. Two more questions in. Thank you, Dr. John.
See you guys.
Regina,
Cheers.
you have one. Regina, you have one more, and then we'll get to Vlad.
Yeah, I was just wondering about the PAD in your arms. How do they know if that's what you have? Is it still just based off of ultrasound or blood pressure readings? Or because before I had the stents, my arms and legs and feet were going numb. Now just my arms are going numb.
Interesting. Does your test account for that, John?
Sure. So we'll take blood pressures in the arms, and there's other studies. It's called pulse volume recording, and that's where we use cuffs, and they inflate to a pressure that is sensitive enough to monitor the swelling and contracting of your arms each time your heart beats. So we can look to see if there's any complications there. But usually, and I am not a physician, but most often the reason we use the arms as references is because it is much less frequent that there is blockage in the arms versus blockage in the legs. But if you're experiencing, you said numbness, are your hands, do you have skin discoloration, or have you had any unusual hair loss in your arms? Have you had a cut on your arm that has a hard time healing?
As far as all that, no, but the numbness and tingling is quite often still.
Sure. And have you been assessed at all for peripheral neuropathy?
Oh, like what kind of testing? Because they didn't really do any testing that said that. They were, before all this, it took them 4 years to figure this out because I guess of my age, no one sent me to get tested for this. So they were treating me for neuropathy and giving me gabapentin.
Okay. And do you have diabetes?
No.
Okay. Yeah, I'd be happy to in offline, and this is part of what we're excited to do, is to learn about where you are and provide some guidance on physicians that have a particular interest in this area, so that they could more closely evaluate you.
And very soon it'll be on PADtest.org. We're going to get that all squared away one by one. Those names are going to be going up next week as well. So everyone's going to have access to the sites that have the PADnet device, which, what I love about it is just that it has the ABI, it has the PVR with the ultrasound, And it also has the TBI, which, the TBI I think is so important for diabetics. And I think it's under, valued, in terms of its, because I think it's really important. With a general ABI, we get a lot of false normals, especially in those patients that have the really hardened arteries that are non-compressible. For example, a lot of diabetics in advanced stages. And so what I like is that you're covering all bases with your technology, which I think is really good.
We're going to need you to be speaking in front of them because you just nailed it.
Well, I believe in it. I believe in what you guys are doing. Anything that we can do to get, on the front lines, and get in front of these patients, I think is really key. And Vlad, you have one more question for John Roman, CEO of Biomedics. You have to go ahead and unmute. Maybe I can help you here.
Joey. So
go ahead and unmute, Vlad.
Oh, can you hear me now?
We can hear you. Thank you for joining us from Vancouver.
Yes. I recently started experience light heart pain, which is comes and go, and also cramps in my legs and different parts of my legs, which is also comes and goes. And I was sent to arterial duplex lower extremity bilateral test. And I just want to ask, first of all, which test for P.A.D. more accurate, arterial duplex lower extremity bilateral or ankle brachial index test? Which test most accurate?
So it's an interesting question, and they're both important, and I'll explain briefly why. The technology that uses in PADnet is referred to as physiologic technology. And so we are monitoring the change of volume of things, whether it's of your legs expanding and contracting, or looking at the volume of blood that's flowing down either your arteries or your veins, versus duplex ultrasound is imaging. And so that imaging, it's looking directly at that blood flow. So what's nice about imaging is you could see it and can pick up plaque, which sort of builds up in our teeth and could be building up in your arteries and compromising blood flow down your legs. What is a limiting factor of duplex ultrasound is its ability to sort of understand what they refer to as the hemodynamic significance, so the actual impact on blood flow. And so the combination is great. But if I would say that duplex ultrasound, if you've already have that, that's very good technology, often reserved for vascular labs. And so I think that it sounds like, and did you have questions about your finding, or do you feel like that was good feedback on the post-test?
I'm concerned it's how we did it, because when we started doing arterial duplex low extremity bilateral on me, the second tech joined them and start doing ankle brachial index in same time. And that's what worries me in terms of quality. In other words, if one test if we do it in the same time, affect another. Should we do it one after another? That's my question.
So good question. For the ABI test that you had, ideally it is done after several minutes of rest, 5-10 minutes of resting. So that's of you not moving around, ideally lying down flat or supine, and that way your legs are at the same level as your heart.
Yes, we did not. We did not do that. And can that affect arterial duplex low extremity bilateral result?
Yeah.
It can.
If you're moving around, movement or not being at rest can impact the results of the ABI test. Of the scan.
What about arterial duplex low extremity bilateral? Can it impact that result of that test, of second test?
Possibly. It depends. I mean, that's a question that I would defer to Dr. Phillips. But maybe that's something that we can follow up on.
So can I ask Dr. Phillips about that?
Yeah,
If
he's not here. But I think
Oh.
that Vlad brings up a really important point, John, and this is where I think that your technology helps. Vlad, there is a big gap, right, between the time that you started experiencing these symptoms and you have the test, what, weeks later, and then you have to wait even more weeks to get another appointment with your primary care to get the results. And then that doesn't even include the time between getting the referral and then making an appointment. How does that affect your mindset? You've been scared. I mean, you've been calling me and you've been telling me that it's scary not knowing because of this big time delay from the moment you're experiencing symptoms to still more than a month later with no answers.
Well, I wait for the angiogram of my heart right now to do, but I did this arterial duplex low extremity bilateral with ABI. But the problem is we did this both tests together with not let me rest, which is required for ABI, you say correctly. So I cannot trust result of both tests based on that, correct?
What I'm asking, no, I think a lot of them do those tests together, and even this PADnet technology combines it. It performs the ABI, it performs an ultrasound, and it performs even the toe brachial index, all with one set of devices, and they're performed at the same time. And so it might be done. We just need to understand more in your case, and we can't make the assessment for you without having been there in the room and having seen the results. But my question to you, Vlad, is, and your concerns that you're expressing right now actually speaks volumes and almost answers my question, and maybe it's just rhetorical now, that it's scary, right? That you have to wait this long, and there's this time delay between the moment you feel the symptoms to the time you finally get to the test to the finally the time you actually get to discuss the test and the results with a primary care physician. So you're left right now, Vlad, and you're scared. You have no answers.
Well, I just want repeat that test because I want to repeat that test one after another, so it's not would be in the same time for accuracy.
Right.
You know what I mean?
Yeah. And I would, that's how you feel, I would share that with your physician.
Yes.
And our job is to make sure that the physicians that you're seeing in a primary care setting have access to the type of technology you need to give you a better understanding on the health of your arteries.
Yes.
But IBI also important to do. If my artery show okay, IBI still needed. If I experience that symptoms, the light.
I think the next step would probably be an ultrasound. Thank you so much, Vlad. And I think that, John, and it further just, I know he wasn't addressing, but just you can see, the fear, the anxiety that this causes with the waiting game. And with having your device or having a testing device on the front lines with the primary care, with podiatry, where the patient can have, there's no delay between the point where they're presenting with their symptoms and actually getting the test, which could be weeks out. And then it's weeks out again to get the results and have those results discussed. Can you just address how your technology and having it on the front lines as it is actually reduces the gap and mitigates that fear, that anxiety that these patients are expressing?
Sure. I'll give you a real life example. We had a podiatric physician in the Washington, D.C. market. He had a longstanding patient who was a dentist and did a PADnet study on the patient. It was interpreted remotely by a vascular specialist in the community. It was going into winter holidays, and the specialist immediately called the podiatrist and said, I am very concerned about these results, and I would like to see this patient right away. Now, I know the specialist is usually booked for 4 weeks, so usually a month out, but cleared his evening so that he could see this patient and was able to perform a revascularization procedure
Wow.
that he was positive certainly saved the foot and
Wow.
possibly the limb. What I was so curious about, because a couple of things. The patient had been seeing this podiatrist for some time, and I was a little concerned that the patient might be upset with the podiatrist. But it was the exact opposite. The fact that the podiatrist was able to collaborate with the specialist and make a priority of his patient to see the specialist and have a successful procedure done, the patient was so overwhelmed with gratitude to the podiatrist because he enabled this kind of access. And it was the right decision to move this patient, not from the back of the line to wait 4 weeks, but to go straight to the front of the line. That's really exciting. I think that's the power of these community-based collaborations.
I love that. I think that that's absolutely amazing. I love that you even have that personal story, and that it still inspires you and that it's right there at the tip of your tongue. I really appreciate that. Before you go, again,
Yes.
one more thing. I wanted to see if anyone would be willing to share their journey to diagnosis and the struggles that you had. More than 70% of people who were polled in our groups said that upon presenting with the textbook PAD symptoms, they were actually offered a different diagnosis. And I'm curious if anyone wants to share that story that will further prove that this testing as frontline is really critical. Anyone have any of those stories here? I think most of the folks that I see here have all been diagnosed actually way too late. They presented in later stages versus earlier stages.
Mine, they said, was a pinched nerve in my back.
Oh, wow. How long between that time, and what other treatments were you offered for that pinched nerve that never actually brought you any sort of relief?
For like 2 years, they gave me naproxen and cholesterol.
Oh, wow.
And it wasn't until I went to the ER and a cardiologist put the dye in that they found it. And by that time, when they got me in the OR, they said I was literally hours away from dying.
Yeah. Well, I'm so glad that was identified. I have my personal story is actually through one of my parents who was complaining of what he thought was lower back problems. Actually was misdiagnosed to the point where had a lower back surgery done and was just not recovering, and was advised that just needed to take time for that to heal. Now, obviously, I'm biased, and one might argue I think everyone has P.A.D., but I took the device to my family and I did the study and saw compromised blood flow in the legs, was sent to a vascular specialist, and the symptoms that he was describing as lower back were really upper buttock discomfort. And so had piggyback stents done, so 2 stents placed in, and was walking and playing golf a week later. And that is those straight true story.
That's amazing. But that was after you already started the company.
It was after I started the company, but it's when I knew, I will say that originally, like many, that I thought that the people that needed our equipment would be the Dr. Phillips of the world. And that we need to go places like the Mayo Clinic and to Cleveland Clinic and to Mass General. And it actually took conversations with the specialists who explained to us the 2 typical problems. One, either that too many people are referring patients that don't have vascular conditions to them, and it's just that takes time to navigate, or that they're not seeing them soon enough because the primary care community is not aware of the disease or doesn't think they should be doing it, or they don't know what to do with the results. And so I had been in telecom, and technology had advanced to the point now where I knew I could securely take the information from the device and make it remotely available to a specialist. And that's where we really leaned into the community-based collaboration approach.
Oh, that's amazing. We always, I mean, there's always that personal touch that really drives it and keeps you going, right? Every single day. That's why you wake up every single day.
We say we live vicariously through our customers, and every single employee at Biomedics feels that way.
Amazing. I can tell. I mean, when I work with both Chris and Adara, their passion is amazing. And one of the other things that I think is really great about our collaboration is, and I wish more companies would do it. Companies get emails from patients all the time, asking them questions about PAD, and it's a really, because you guys have a really good opportunity, and more money than we do at the Global PAD Association. We're a 501c3, and so it's nice that I love our partnership also in that those patients that do present to your website with issues and need questions answered, Adara sends them to me, and we're able to track all of those that come through your website, and we're able to help. And we're able to facilitate getting them, life and limb saving care, or at least find them the answers that they need in real time, so that they're not, racking their brain and relying upon Dr. Google, which is so reliable.
Right. Well, we feel the exact same way. I mean, we really are excited about the care that can be accelerated and delivered more cost effectively, more timely through this collaboration.
Thank you so much for all of your time. I'm really excited going forward, and we're going to make sure you visit padtest.org, and it's going to be continuing to get populated with more and more doctors as we go over the coming weeks. But really excited. Thank you so much from the bottom of my heart, John, for supporting us and supporting this initiative and this partnership.
Oh, thank you for all you do.
Awesome. And I'm going to open it up now.
Can I ask him a question?
Of course, Marcia, go
sure.
ahead.
Before he leaves, I was curious, maybe my idea is too simplistic, but isn't an ABI test basically taking your blood pressure in your arm and then in your lower extremity?
Mm-hmm. That's correct.
Well, then I'm curious why you have to go to labs. Why can't they do it right in the doctor's office, just with the simple blood pressure cuff?
That's a good question.
So it is a great question. And unfortunately, the arteries, so the blood flow in your arm, it can be assessed easily with the blood pressure device that you're talking about in the arm. But doing that same calculation in your ankle or down at the toe is much more challenging, just because of the physical structure of things. And so we're not able to use that same cuff technology at the ankle that is used most commonly in the arm. That's why that specific technology is not able to do that. But your point about why can't I have this test done in the primary care setting is heard loud and clear for me, and we agree with you. And that's what we are working to do, to make that technology readily available in the primary care setting, so that you can have it done just like you have that regular blood pressure done.
Thank you. So then my at-home experiment with my blood pressure cuff was completely a fail.
Well, yeah, it probably is. I think it would be, I would not rely on the results of that. That would be hard.
Okay. Thank you.
You're welcome. Great
Thank
question.
you so much, John. I'm going to open it up actually to everyone just to share their journeys to diagnosis, because I know everyone has a very different journey, and it'd be interesting to hear your journey to diagnosis, because I know even for Douglas had multiple procedures before he even learned he had PAD, and which I thought was interesting. So thank you, John. You're welcome to stick around and listen in, but we're going to start opening up to others to just share their journeys to diagnosis.
I just have one more add to my question, if I can.
Okay,
Sure.
Vlad.
So if I did this both tests together and my arterial duplex low extremity bilateral show no evidence excess of significant arterial disease as a result, but since it was done parallel with ankle brachial index, can I trust that or not? That's my question.
Oh, I unfortunately, I do hear your question, and I understand that it's a straightforward question to ask.
Yes.
The answer, unfortunately, is not straightforward. Not being your doctor or the person that did the test, because there are a lot of factors that can come into play. Believe it or not, things like room temperature, body position, movement, stress level. We've talked about if you'd had caffeine or nicotine. There's a lot of things. So what I would encourage you to do is to take those results back to your physician and have them walk you through those results for you, so that you can feel comfortable in. I'm assuming that they've sent those to you, so they're saying these are the results and they're satisfied with them. But asking them to walk through those results with you so that you can be more comfortable and decide what to do next.
I don't think Vlad's even gotten the results. Have you, Vlad? You haven't sent them to me.
I got the results, but see, one technician was holding my right leg to do arterial duplex, lower extremity bilateral, and same time another technician was placing cuff to pressure cuff for ankle brachial index. So my question is, how ankle brachial index affect result for artery? It can affect result for arterial duplex low extremity bilateral if we do it same time or not.
So I think that he's answered your question, but I think that it's a question he's saying is more appropriate for your discussion with your primary care. If you have gotten the results, we're happy to also have a doctor just review them too. And we also in our network, we have, and even on our website at PADtest.org, you can look at the standard sheet for results and see how doctors actually view those results. And you can go ahead and compare your results to the standard on there. When is your appointment? I think you said it's coming up next week with your primary care.
Well, that's for my heart study. That's for my angiogram for my heart.
Okay, when is your primary care physician meeting with you about your results? Is that coming up?
No, the cardiologist only meet me 2 months later.
Okay, then that's something that you and I are going to work on offline. Part of what we do with the Global PAD Association is we meet with people offline and we help them to make sure that they do get an appointment scheduled with their primary care so that they can get those results read. And Vlad, we're going to work on that offline. So we'll take care of that later. But again, John, thank you so much for joining us. We really appreciate you and all of your time, and enjoy the lacrosse game.
Thank you so much.
It's
perfect timing. The next game is at the top of the hour, so I appreciate the time together. All the callers' times, really fascinating conversation. Thank you, Kim.
Thank you. And I'll open it up now to Doug. Let's go ahead and your journey to diagnosis, and we'll start with you.
Well, I have a question for Vlad. You know we're all here for you, buddy, right? And how are you doing with the up and down and the daily, the insanity of what we all go through? How are you doing with that?
You ask me?
Yeah.
Well, it's relatively new for me, that symptoms, what I experience. So I understand it can be very serious disease if it is, but the problem is I don't know how severity that is in my situation, because what I experience, it's light heart pain, which is comes and go, and cramps in my legs, which is also comes and goes. Not every time, but besides test, that test, which I did arterial duplex low extremity test, but it was done together with, they not let me relax for ankle brachial index, so it was not accurate. So I need to repeat that to get more accurate, reading. And so I don't know what else to do, basically. You know what I mean? Because what's important is to cuff that disease earlier, to start treatment, right? But besides test, I don't know what else to do.
Just wanted you to know that we're all here for you, okay?
Okay, thank you.
And it's that story that we go through. I mean, I saw my primary care doctor 3 days after I fell in a yard and I couldn't walk. And I mean, it was 2 years and about 4 months later when I was officially diagnosed with P.A.D. But I had stents, an arterial bifemoral bypass. I had an axial bifemoral bypass. So I had gone through all this stuff and kept going through and kept getting, I sent from one doctor to another doctor to another doctor before I was officially diagnosed. And it was only after I met Kim in the group that I was actually able to get to a doctor who actually said, Mr. Salisbury, do you know you have P.A.D.? It was like, no, I never heard of it. But this was after I had everything else, and my vascular surgeon who did both surgeries never even mentioned P.A.D. Never told me to stop. I was smoking off and on. Yeah, I wasn't eating right. I was trying to eat healthy as I could, but I wasn't eating right. But I was working and still doing all the stuff that I was doing, but I just kept having more problems and more problems. And it was only after I met Kim and they got me hooked up with Dr. Walker out of Houma, Louisiana, was I officially diagnosed. But that was 2.5 years later, after I had all these other procedures done. And that's part of that insanity. I mean, how many of us in the group, we weren't diagnosed right off the bat? We've been through all the things that we've been through years later before we actually got diagnosed and got to the right doctors. I mean, my Dr. Walker was not in a hospital. He was associated with a hospital in Houma, Louisiana, but he had his own place. And
I came this meeting I came to this meeting today a little late. So what you was talking earlier, it's some type of new device what helped diagnose that, right? Some type of new device.
Unmute.
Thank you. It's a new device. It's called PADnet, PADnet, and it combines the ABI, the ultrasound, and the TBI. So when you express concern about the ABI and the ultrasound being done together, I actually see it being done quite often. And in fact, with this particular device, it offers the ability for a doctor to perform an ABI, an ultrasound, and a TBI, where they place the cuff on the toe, all at the same time, and be able to get a lot more information that a doctor may use to give you a more accurate diagnosis. What happens a lot is frontline, a patient is offered just the ABI, that ankle brachial index, where they place the blood pressure cuffs on the arms and the legs, and then they compare the two to see if there's a difference in pressures. What you don't want is low pressure in your legs, and that's really critical, and that's what they're trying to discover. That low pressure in your legs could be due to lack of blood flow, some potential blockages in your arteries in your legs, and that is concerning. That's what we call peripheral artery disease, and that could be because of really hard calcium. It could be caused, by chronic clot, fresh clot, whatever it might be. Okay, so they can actually combine these different tests into one, as PADnet has done. And if you want to learn more, you can go to Biomedics, BIOMEDIX.com, and I can go ahead and put this in the thread here, and maybe Joshua can put it in the YouTube thread as well, our producer for the YouTube clips. Just if you want to learn more about that particular technology as well. Go ahead, Douglas.
So let me ask this: as you're talking about that, my first thought was my primary physician at one point actually took my shoe off, but he never attached anything. He didn't check my blood pressure. He just took my shoe off and sock off and took two fingers and did the 2-finger thing. So with these new devices, are we trying? I mean, how do we? So I guess it's up to the primary care doctors to get out there and learn this new. And how do we get those primary, like the primary doctor I have here? He was the first one who ever took my shoe off after all the other doctors I've been to. And how many, we hear that all the time, don't we? When's the last time you've been to a doctor and they didn't actually touch you? You know? So at what point does that make sense? So do they go together? Is there one before the other one, or is that what we're trying to help fix?
I mean, step one is to even get the doctor to touch your feet. I mean, that's definitely step one. That's a really good point, Douglas. That I think that is up to the patients now. If the doctor does not have you take off your socks, you take off your socks and say, "Hey, doc, check my feet, touch my feet." And we have that acronym, CHAT, C-H-A-T. Check my carotids. Even take your fingers, take your stethoscope, check my carotids, my carotid arteries that feed your brain. You really want those checked often. Check my heart, check for AFib, check for atrial flutter, check, to see if there's any valvular issues. There's a new stethoscope, Echo, EKO, that actually makes it easier for doctors to even check for valvular issues in your hearts. Check your abdomen. A stands for abdomen. Check for an aneurysm in your abdomen. You say, "Hey, doc, check for a bruit." It's spelled brute, B-R-U-I-T. Check for a bruit. And what that means is check for that turbulent flow in my abdomen. And that's the same thing what they're looking for here in your carotids as well. Check for that turbulent flow or that bruit. And then check your toes. T stands for toes, right? Make sure touch those pulses. See if there's low blood pressure. See if you can feel anything. Many people in our group say, "Hey, my doctor couldn't feel much." And so they sent me for an advanced vascular assessment because of that. So even just the touch can tell you so much.
So most primary doctors should be able to take 2 fingers and know how to do that.
Right. 2 fingers,
Douglas.
2 seconds could save life and limb.
Douglas. Yeah.
Yes,
I think that this is a great idea for this. What did you call it, Kim? I forget what you call it.
PADnet.
Yeah, I think it's a great idea, but where I live, it's all big health networks, and they, not the primary care physician, but the networks determine so much, and I can't see them, at least not the health network, paying for these machines. I just can't see it. It's all about the bottom dollar, and it would cost, I mean, even though these machines aren't that expensive compared to going to a lab, I can't see them spending the money to do it unless the physicians themselves can buy it.
Well, the good news is that they have infiltrated the market, more than 1,200 across the country, dietary clinics, vascular clinics, primary care clinics. And I think that there are more and more of them, especially in more rural communities. And I think that that's where we're seeing the highest populations of PAD patients, especially ones that are a toe step away from amputation, that are getting diagnosed way too late. And many of these areas, they have shortages of primary care physicians, of vascular specialists, of podiatrists. They're few and far between. And we have many of these clinics that just have nurse practitioners. And I think Douglas would tell you, there are a lot of areas in Texas in particular where all we do is work with nurse practitioners in small clinics. And physicians are starting a chain of these clinics that are spread out across these rural communities, where the physician is they're a supervising physician for these nurse practitioners, maybe 4 or 5 of them, and across, let's say, an area that's pretty large, maybe hundreds of miles, and having these devices in those clinics are imperative to get people diagnosed sooner rather than later. I think you're right. In some of the areas that, are densely, that have a lot of these healthcare systems, you have universities, you have large facilities and such. It might not be the right market because there are a lot of options for patients to get tested. But even what John Romans, the CEO of Biomedics, was saying, that in some of these communities, where the patients are struggling to navigate the system, some of the primary care physicians or podiatrists that have their own office that is not necessarily attached, they're within that health network, but they're not necessarily attached. They might be a few miles away. They're the ones that are saying, hey, you know what, we can make a decision to put this in our clinic, and just one patient a week that they perform the test on will make it worth their while in order to pay for the monthly subscription to this device.
See, that's the thing. My primary physician, my primary vascular surgeon here in Beaumont, had 6 different locations. For about a year, I was with him. I never actually saw him in person. It was always his nurse practitioner. I never actually saw him. Not one time. It was always her. And she would say, I'm going to tell him, or he told me to tell you this. Because he was either in San Antonio or El Paso or Austin on that day. But in the one I see now, he has 3 locations, and you see him at each location. So he goes from one. So
Yep.
I see him in Seguin. I have not seen his nurse practitioners in the room, but he's always been there. When he goes to Corpus Christi, every patient sees him. When he goes into Austin, which is another hour up the road from where he is now, he sees those patients, but his nurse practitioner is always in there. But the guy here in Beaumont, I didn't see him for a year. I knew his name. I didn't know what he looked like, but I knew his nurse practitioner. So it was like, that's the crazy part, isn't it? And we talk about this. How many times, the last doctor visit I had before I got this one, I don't think the guy ever touched me in 6 months. I don't think he ever touched any part of my body, even with the stethoscope. He could have at least walked over and checked my chest just to make sure, check my, my breath. Well, are you still breathing? Yeah. But he never touched me. So how many times do we hear about that where the doctors never actually touched that person?
That's a question right there. If doctors aren't touching their patients, why would they even use a machine like this? They're not even bothering to touch people. I mean, that's absurd to think.
They never touched my mom 2 weeks before she died. If they would have literally just touched my mom's belly, they would have discovered some serious turbulent flow due to her aneurysm dissecting.
It's that like, so I walked into, I have an earache, and he said, put your knee up here, and he bops my leg, and my leg goes, he said, all right, you're okay. It's like, hello, I have an earache. What are we talking about? I was in the hospital. Remember, I was in the hospital that time, and the one doctor walked in. He said, I had to look your condition up. And my first thought was,
that gave you confidence.
Right out that door, because it's like, if you had to look it up, I'm in trouble.
Well, I guess I have to give it to my vascular surgeons locally here. They're retiring, and Kim's been fighting to help me find new care. But they always have their hands on me, checking different pulses, even the bypasses to the 2-finger test. They were always hands on. And so was even my the orthopedic surgeon that I see. he's very hands-on. So I guess it's maybe a different thought here. I don't know.
And I think Marcia, we'll get to you, but I think Kim really addressed that. How often do you see that with everything you go through? How many different doctors out there that actually take that time or they don't take that time? And you probably see that with dealing with all of us as much as you do. And how many times have you heard doctors say, well, ain't nothing I can do for you. See you later. And
Oh
they
my
never
gosh, I
even,
hear that all the time.
Mm.
you know?
And to their credit, so many these doctors are so busy, but by the same token, if they would take a moment and just stop and just listen. And that's why I always tell people it's really good if I'm in the room, right? How much of a difference does it make, Douglas or even Marcia, that you've had me on the phone with you? Do you think it makes a difference having that extra advocate in there to help fight for you, to help get that doctor to just stop for a second and listen and be more engaged?
It
Well,
absolutely helps. It absolutely helps. I'll tell you a happy story. I'm fortunate enough to live close to a pretty good medical hub near Gainesville, Florida. That said, it's still like 45 minutes away. And living alone, I have to schedule the logistics of people taking me to a procedure and then bringing me home because you can't drive. But I'll tell you something. PAD is very much a multidisciplinary issue. It's a teamwork approach. And it goes from the x-ray techs that do the ultrasounds to the nurse practitioners and PAs that take the information to sometimes hand on to the doctor, the surgeon, because he's busy at another location. And the patient, a good patient, will understand this process, especially in this day and age of, oh man, 15-minute appointments for my primary, and the primary is like rushing you, or some primaries do. Mine don't. But that said, the multidisciplinary approach really begins with the patient themselves. And that's where education and sharing your story is so important. My story, quick and short and simple, is that I'm in a Facebook group for PAD. That's how I ran across Doug and Kim. And I found out about this group through actually being very involved with dementia advocacy, which is another story. But anyway, I posted in there that I went and saw a vascular surgeon and he did this procedure, and I woke up and he told me, well, we couldn't get access. And so your choices are to live with the pain or have an above knee amputation.
Wow.
And I'm like, well, I'll get back to you on that. Fortunately, I do have a medical background. I worked in the ER as an x-ray tech. And so I do know how to ask the questions. And when I told the story in the group, Kim actually came in the post like right away and said, stop, get a second opinion. Where do you live? And I told her, and she said, go see Dr. Arthur Lee. And so I looked him up, did some research, and reached out through my insurance and got it approved. And do you know what? This was Christmas time. I didn't even meet the man until like 10 minutes before the procedure. He came in and I said, thank you, doctor, so much for taking me as a patient 3 days after Christmas. And I follow up with him. I have more stent placements to go. I'm slowly turning into the bionic woman. But that said, I'd much rather be a bionic woman, still walking, still living, having quality of life than having an above knee amputation.
Can I ask you a question?
Sure.
So before you met us on the group, before you met us, in all the appointments you've been to, I hear this a lot and this goes for me too. I didn't know the questions to ask. I wasn't aware to ask this or ask that. back in the very beginning? And if I had known those things in the very beginning, would it have made a difference where what I went through? Absolutely. Because I would have said, hey, time out, hold on, let's take a break, before we do this. So, and I think we run into that a lot here. How many of us in the beginning are we just trust the doctors and we go along with it, or we just don't know all the questions are the right questions to ask?
You hit the nail on the head right there. Actually, I kind of self-diagnosed myself, having enough of a medical background to be dangerous, but having enough common sense not to fall down the, oh my God, I'm dying of every disease Google tells me. If I had had information available to me about, do you get tired just walking to the mailbox and back? Don't wait. Go get checked. It would have saved me 4 years of time and pain and agony, chronic pain at a level 5. That's my daily, that's what I live with on a daily basis. Chronic pain at about a level 5.
Wow.
Yeah, I'm still walking. And there's other procedures I can have done to address that are also interventional in nature. But if I had had some information from the get-go about PAD, and I'm a medical person, you'd think I'd know. It would have saved me 4 years and possibly some of the stents that I'm looking still to have placed.
That goes with, I think Regina has a question we'll get to. I think that goes with the smoking and the eating right and the walking, walk, build those collaterals. If we didn't know all these things, if my doctor had told me in the beginning some of these things, or if I had been able to ask these questions, how many of us in the room are dealing with PAD, would it truly have made a difference in the procedures we've been through and all of that? Yes. I mean,
and think about the financial saving, the money that would be saved medically by prevention, by being proactive. That's the thing, is that we wait till it's too late and then we're told have an amputation. Well, it's the same thing with so many other medical issues. We wait till it's too late. We need to address things proactively.
So if I have a procedure, we do a procedure twice a year. I promise you that's going to be cheaper than having an amputation, and what that cost goes through over a period of time.
Absolutely.
And Regina, you have a question?
Yeah, well, basically, I just wanted to throw this thought in there. I've been trying to figure out, like the doctors have been trying to figure out what was wrong with me for almost 4 years now. And finally, I had a doctor that just said, because I complained all the time of my legs hurting. And I would tell them they're not working right. Something's not working. And they would tell me it was fibromyalgia and this or that and give me different medicines. And you need an antidepressant. And, I didn't need that stuff. I needed somebody to figure out what was wrong with me or listen to me. And I think because I was 45, they're thinking, they're not even thinking of this type of diagnosis. And then finally, one doctor said, well, let's just do an ultrasound of your legs. And then lo and behold, it come back abnormal. So luckily I was able to get with Kim, and she helped me find a doctor that was able to, check on some things and do some tests and stuff. But I think there needs to be more attention, even younger people, that when they go into the doctor and say, hey, I have these symptoms, at least it should be on their radar or considered. I mean, I just don't know how to get people to listen, get these doctors to listen or whatever.
And that's one thing that we're looking at, maybe doing something. We have this DEI committee that we meet every week, every other week, and we're trying to figure out some brochures and an approach. We ended up with a grant, and maybe one of the ideas being tossed around is to get a large contingency of members of our group who want to put out these brochures and bring them to their primary care. And as part of that, for every person that brings it to their primary care, get a picture with that primary care person with their brochures, and we'll highlight those doctors, for being on the front lines and taking a moment to understand PAD. And so that is one of the ideas that we're tossing around. And so if you want to join us in brainstorming some opportunities that we can do as patients, I'm happy to have you join.
Great. I love it.
Yeah. How many of us feel like a car sometimes? Here's the thought. I'm driving my car, but it acts up. Every time I bring it to the mechanic, it seems to run right, don't it? Or he'll change this part, he'll change that part, he'll change that part because he doesn't really know, or he's just guessing half the time. How many of us went through that in the beginning, and we talk about pain. So I tell the mechanic, this is what happened. And he says, it can't be that way. Sorry. Well, I drive the car every day, or I know how I feel every day. So I know how you feel with the 5, living with the graft and in my living with my graft. I know how that feels every day, but how hard is it to describe to somebody how that feels when they don't understand it, or they don't feel the same thing? How hard is it for us to describe pain sometimes?
About
That's
as
a
hard
really good
as a
question.
dementia caregiver describing what it's like to care for their loved one
You saw
24/7,
my post
and
the other.
somebody pops in once a month and says, oh, there's nothing wrong here, everything's fine. It's like, hey, you don't live this 24/7. So again, it's back to telling our stories, being passionate about it, but not wallowing in pity about it either. We have strength, we have answers, we have solutions. And one thought I love this, is it DEI you said, Kim?
Yeah, the Diversity, Equity, Inclusion Committee.
Cool. I'd like some info on that. I'm on
Definitely.
the board of directors for Elder Options in my area. And Elder Options is not just for our elders. I'll tell you that right now. I would love to see some interaction with your local agency on aging, is really what Elder Options is, which comes from a federal grant that's broken down by state, and then every state is divided up into public service areas. My area is PSA 3, and we cover 16 counties, the largest area, and including the villages in Florida, which that's a whole area by itself. And so I see ways to get this information out there, not just by telling our stories, but reaching out to your local agency on aging and saying, hey, this is a big deal. It impacts so many things, and it can be so subtle. Let's get some word out before it's too late, before people are looking for amputation. And then Meals on Wheels gets involved, home health care is involved, driving people back and forth to the doctor gets involved. All of these things cost money. And if we can beat it before it gets to that point, we're going to save a lot of money, and we're going to save a lot of lives.
And
I agree.
You nailed that part there, where it's going to take. I'm still a member of my Alzheimer's group, and somebody addressed that the other day with me about, well, why didn't you do this? Why didn't you do that? And I said, where'd you get that from? They said, well, that's what the book says to do. And it's like, at 3:00 in the morning, the very first time I had to clean my mom up, I said, the book does not describe that way. It's like, until you've been there, you don't. And I know that sounds ugly, but until you've been there, you don't know what that's like.
It's true.
And that's what makes it so hard. But Marcia, I can actually get you some brochures if you want to hand them out. We're even personalizing them for each person that wants to hand them out. You're welcome. We can put a picture of you or your area on the front and actually have a letter from you telling a little bit of your story and the importance of it. I can share some of that, with you and some examples as well, so you can see what others have done. I'm still waiting we need to do one for Douglas. We did one for Charles. We did one for Robert Castleberry in the group, who has Pad Life Outdoors on YouTube, if anyone's listening and wants to subscribe to a cool channel. You
And
can
the
also
thing about
subscribe
the
to our channel.
DEI, explain the DEI. The DEI is that exact, it really is, comes down to us, like you were saying, we have to become engaged. We have to become involved all
Right.
the way through the picture, not just when it's convenient for us, but we have to become and stay engaged. And
It's an
the
inside
doctor,
out job. It really is. It starts with the patient. The patient has to be educated first, and then it trickles out. That's how all of this works in this day and age, when everything's so top heavy and doctors are so busy and paying off student debts of enormous amounts. It starts inside out. And that's why I love this approach of, here's my story. I'll take it to my primary. I'll share it with elder options.
Yep.
I'll share it online in support groups. And this is how ripples start.
Yeah.
And ripples can turn into tsunamis. All right.
and we've heard that so many times from doctors. We've done these great meetings, and afterwards we've heard doctors. I've heard a couple really high up doctors go, I never thought about it. I never thought about it that way.
Right.
I never, until you said that, I never thought about it that way.
Patients are becoming the educators of their doctors. And I learned this firsthand over a decade of dementia caregiving. And now my passion has trickled out into this PAD thing from my own personal experience with it.
And it's interesting, as an X-ray tech, I'm sure that prior to learning from us that there might be a different practice that would be an option for you, you were referred to only a vascular surgeon. But being an X-ray tech and learning that an interventional radiologist might be an option for you, I bet that was pretty eye-opening.
It was one of the reasons I fell in love with radiology in the first place, because this interventional technology is amazing. It's sort of like, do you remember that old movie, The Fantastic Voyage, where a crew of scientists were miniaturized inside this little submarine and injected into the human body? That's what interventional radiology is like. And it's in so many areas now, and it's really non-invasive, right, relatively speaking, as opposed to getting cut open. And they do these amazing things now. They can clean out plaque inside tiny little blood vessels. They can access blood vessels from your ankles now. There's little tiny blood vessels. It's amazing what interventional radiology can do. They're doing pain relief interventional radiology now.
Right. You were mentioning that you learned about DRG. If you wanted to explain it, I saw you mentioned it as well. Actually, you learned about it through our show.
Yes, I did. It's a great group. DRG stands for dorsal root ganglion stimulation therapy. That is a mouthful even for a doctor. So, of course, they shorten it down to DRG. And I don't know if you all have ever heard of a procedure called a spinal cord stimulator, where they put leads in your spine, and then it's sort of like a TENS unit. They pulse these little things that interrupt the pain cycle in your nerves. And that was okay for a lot of people, but some people had problems with the leads falling off into the side, into the facets of your spine and getting caught, and it was uncomfortable. And then controlling it got to be an issue, because they'd turn it up, say, for their foot, but then it bothered their hip. It was too powerful in their hip. And so by addressing the ganglions in the roots of your nerves, which are located down near your spine, your sacrum, down in your lower back, they they put these little tiny leads in the ganglions, the nerve roots there, and those nerve roots are specific to very specifically located areas like your toe, your ankle, your foot, your knee. And they've had tremendous success eliminating pain for people that like can resume their lives again. I've had my life put on hold by going to doctors about 8 times a month, and it interrupts with my teaching Tai Chi and Qigong because it's hard to walk, and I have a gimp in my walk, and I walk around with toe pain, like 5 out of 10 pain on most days. And so I am a candidate for this procedure. But getting back to insurance, my doctor and I discussed it and determined that we're going to do some legwork on this first. And he diagnosed me with something called, what is it? Critical regional pain syndrome. I think it's called CRPS, which is a weird thing. And it kind of is vascular. It has vascular symptoms, it numbness, tingling, nails will grow weird, fatigue, different things like that. Well, that could describe a boatload of other diagnoses. So to differentiate from my PAD diagnosis, I'm being sent to have a nerve conduction test on my right foot and toe, which will surely show the nerve damage. And with my 2-year history of this horrible neuropathy and all these stent placements, that paves the way for the insurance to say, yes, this is medically necessary and we're going to pay for it. So those are some little tricks you can do when you go to the doctor to discuss these things. Do your research first. It's important. Again, I go back, the patient is number one, and you got to be your own advocate.
Well, it's amazing. We had a doctor on here one time. They inventing stuff is they're creating a pill that you can swallow that is a C. Actually swallow it instead of doing all these other tests. It goes through the intestines and it gives them a picture of where it goes and what it looks like. And it's in a pill. It's a little pill. It's like that movie. So there's a little guy in this little pill going through your intestines, taking pictures for them. It was amazing, the technology, isn't it?
Well, I like the one that takes that technology to a whole new level, and they were actually testing it out with Game Boy controllers and actually being able to remotely move the little robot, the little pill, robotic pill, around the intestines and drive it where it wants to go with simply a game controller, which I don't know, it's disconcerting, but it's also pretty cool, right? I think it's and Donix, I can't remember the name of that company that's taking that to the next level. But it's amazing what people are doing in a minimally invasive way. And anything we have to do to prevent these major procedures, especially who wants to have a colonoscopy? I mean, seriously. I don't know anyone that literally looks forward to that. I would rather be able to swallow a pill and be able to have that give the doctors clear enough pictures and enough pictures to be able to make a clear diagnosis.
Oh, I just wake up every day wanting to have one. What the heck, I don't think so.
I think that was more of a rhetorical question. My second rhetorical question of the day.
The only issue with swallowing a pill instead of an actual colonoscopy is that if they do find adenomas or cancerous spots, they're still going to have to go in and do a colonoscopy anyway. So my thought is, why be redundant about it? I mean, I do have a history of colon cancer in my family, so I'm not even a candidate for that. But that's another thought. If you're not at risk at all and you're young and healthy, go for it. But as we get older, talking about the car analogy, Doug, I turned 65 last year and I swear my warranty ran out. And it seems like ever since then, I've been having doctor appointments at least once a month.
Marcia?
But I'm thankful that I have these options and able to navigate this nightmare of a medical system we have.
Go ahead, Marcia.
Oh, I was just going to reply. I understand what you're saying about not taking the pill, but on the other hand, people who, because of the anesthesia involved, and if it truly is preventative, like a younger person getting their first one, it might behoove them to take a pill without having the associated risks. It probably would depend on the patient.
Yeah, they actually have these, I forget what they're called, but they mail them to your house and you do a little test yourself. It's kind of gross, but you take a piece of your poop and slab it on this slide and then send it off to the lab, and they can tell within 90-something% accuracy if you have cancer or not. That's great for someone that doesn't have a family history of colon cancer. If you do have a family history of colon cancer, they're not going to do that test for you. They're going to suggest that you go have colonoscopies at least 5 times every 5 years.
Yeah.
Right.
So this conversation always goes south, doesn't it?
Yeah. with all those thoughts, though, Kim, it's like all the tests that are coming up now that we have out there now. With like she was saying, how many doctors do you experience don't know how to go through the ankle or don't know how to go through the bottom of the foot? We had that one patient, I remember, they were going to do him amputation, but the doctor that you got him to went through the bottom of the foot and was able to clear him out. And it was like, is that from one extreme to the other in all the stuff that we're learning?
And that's why we always say, and I think that Marcia Burr will also concur with this, and I think this is what she was alluded to as well. Different doctors, different approaches, different tools, different techniques, different philosophies. It's really important that the patient be informed and get multiple opinions to understand all of the available options so that you or they can make the most informed decision that's best for them. A doctor may offer someone 2 people amputation, and one patient may say, you know what, I really like and trust this doctor. I don't want another opinion. This is right for me. It's best for me. I don't want a revolving door of treatments. I can go to the dentist twice a year and get plaque cleaned off my teeth, but it's too much for me to go in twice a year or 3 times a year to go get plaque cleaned out of my arteries. I want this done and over with. And I want the amputation. Great, fine. That's best for them. But that's better than the doctor saying this is the only option that's available for you and everyone else. Because another patient may come in, like, for example, Marcia, who says, I don't mind being a bionic woman. I don't care if I have a full metal jacket by the time we're done and I die fully metal and they can't cremate me and there's still going to be little metal pieces left over. Like, I don't care. As long as I have my feet, let's do everything possible to save my feet. If I'm on deck for amputation, why not try? And why not try again and again if I'm maintaining my ability to walk?
Can I share a personal? This may be the wrong place to share this, but there have been days since I had this axial bifemoral bypass that I thought, you know what? I hate to say this way, but it's the only way to say it. There have been days I thought I'd rather have lost my leg than deal with what I've been dealing with the axial, if that makes any sense. There are times that I have thought about that, and it's like, would I have been better off if he had just done that and not put this thing in me and have to live with this thing like apparently I'm going to have to the rest of my life.
Well, Douglas, only you can answer that question, right?
But that's part of the thinking, I guess, sometimes that we all go through.
Well, I think that's normal. I mean, you've gone through an awfully lot, and having it jabbing you, I would think it would be unusual if you didn't question it.
Yep.
I think that it's important for people to understand the difference between vascular surgeons and interventional specialists.
Yes.
A vascular surgeon, the word surgeon is in there, that you can attach that to the term sawbones or cutting you open. It's very extreme. It's not an easy thing to be cut open. And if some of this stuff can be prevented by interventional radiology procedures like stent placements, then why not do it? It's so much simpler.
Marcia, I feel the same way you do. And my interventional cardiologist kind of felt like it was time for me to consider a bypass and sent me to a vascular surgeon. To my absolute shock, and I think Kim's too, I walked in and he said, "You do not need a bypass." And that's what he does.
Wow.
I thought, why are you going to send me to a surgeon if you don't think I need surgery? And he turned me away. It was the best day, wasn't it,
Aren't
Kim?
you glad?
It was amazing.
Wow.
Well, it's interesting because what a doctor doesn't, and I want to get to explaining and understanding vascular surgeon, versus the different practices in a moment. So remind me to get back to that because it's a very important point. But what I wish that all vascular specialists would do before any procedure, and I think a lot of them do some of it, but I don't think that they explain it in a way that patients understand, is that any procedure is literally not the end all be all. You start the revolving door of treatments. It's not going to stop because it's not a matter of if this potential procedure is going to fail. It's just a matter of when. They're not 100% durable yet in any form or fashion, whether it's minimally invasive or whether it's surgical, not invasive. The only cut and dried is really that amputation. And even then, what we find with patients is it's still a revolving door because it's one amputation after another, after another, after another, as also Alan, who's on here, found out, and Sunshine, who was on here, also found out that it just doesn't stop at one. It always seems to go further and further. And it's a fight every day. And so what they need to do is, we are going to do this procedure. We're going to dilate a balloon, inflate a balloon, push a little bit of that plaque aside. We might remove some of that plaque using what's called an atherectomy device, maybe if it's indicated for that particular case. And then we may or may not place a stent, what they call a scaffolding, to hold that plaque that they pushed aside open. Less is more. The philosophy is today to leave nothing behind if possible, because those stents can cause further trauma in the body and trigger a healing response. Anything that happens to your vessel triggers a healing response. And it's just a matter of how much of a healing response it's going to trigger and how long it's going to take for that healing response, where it's filling up with all the scar tissue, to completely re-occlude or reblock that entire artery and cause symptoms again. So the key with these procedures is, hey, doctor, give me just that much more blood flow. Just that much more blood flow to, number one, if you have a wound, enough blood flow to heal that wound. And then number two, to relieve those symptoms, the claudication, the standard claudication, the pain, the weakness, all of that, with which a little extra blood flow could help suppress, right? Get me to a point so that I can walk, get back on my feet, start walking and growing that network of collateral vessels, those vessels that lay dormant in our body that are so small that you don't even see them light up in an x-ray. And I know Marcia Burke can actually talk more about this as an x-ray tech, but they lay dormant, right? Until your body needs them to reroute blood flow around any sort of significant narrowing or blockages in your arteries. And walking ends up saying, hey, body, wake those vessels up. We can't get enough blood flow down to the foot. as they're walking. So we need to reroute blood flow. And so that's really the potential for these procedures is, so if they do block up at some point, or when they do block up, you've built enough of these collateral vessels that have rerouted blood flow around that area so that you may not need another procedure. And that's what happened in Marcia's case, where the vascular surgeon said, you know what, actually, since your last appointment, you've built some really nice collateral vessels around that block stent. And so you don't need a procedure. Just keep walking. Your body is doing the right thing. It's responding. It's rerouting blood flow. It's creating its own natural bypass, which is really good. And before I send it back to you guys, number 2 is you mentioned the vascular surgeons. So there are 4 different types of practices that do treat PAD. You do have vascular surgeons, you have interventional cardiologists, interventional radiologists, and you have vascular medicine. Vascular medicine is a newer practice in which they really focus on conservative therapy, medicines, and lifestyle modifications. And I think it's really important as they become more widespread across the US that every patient has a vascular medicine doctor. That may be a certification that your vascular surgeon or your interventional cardiologist or your interventional radiologist may also have, but it's worth checking into. Interventional radiologists are the ones that first started doing, it was actually out of Oregon, that it was an interventional radiologist that performed the first minimally invasive procedure to open up a blockage in the thigh. When a patient told her vascular surgeon, I don't want an amputation, not going to happen. And that vascular surgeon went to the interventional radiologists who actually are trained in going into the arteries with wires and trying to open up other areas in the body, other vessels in the body and such. And said, hey, you work with catheters and wires all the time. Do you think you could try something here? And what that doctor, interventional radiologist, was able to do is take a wire into that blocked artery, and the wire was able to traverse the blockage, get through it. And that doctor was able to take a small catheter, then a larger catheter, then a larger catheter, and a larger catheter that just slowly eked that plaque aside and opened up that vessel, which was great. And that really started the process of doctors being able to say, hey, wait a minute, maybe we can do this. And then with the invention of the balloon, they were able to say, hey, we can do it both in the heart and the legs as well. So interventional cardiologists who were doing the heart were saying, hey, wait a minute, we are able to navigate the twists and turns of the smallest vessels in the heart using these wires and balloons. Why can't we do a straight shot in the legs? So they started getting involved with the legs. And vascular surgeons said, hey, these were our patients originally. We were the ones that started doing the amputations and then the bypasses and what are called endarterectomies, where they would open up with a small incision and scrape out the plaque manually. We want to be able to treat the whole PAD patient. So they started learning the interventional procedures as well. And so not everyone in every practice performs these endovascular procedures on the legs, but it's really worth exploring all of your options and having a few in your back pocket so that you can go to each one and use our questions on our website at padhelp.org and look at our Find a Doctor tab and look and see the different criteria that you can actually go to the interventional radiologist, the interventional cardiologist, and the vascular surgeon to say, hey, do you do this? Do you do that? And then you can go back and say, you know what, based on my presentation of disease, based on my understanding from all of these doctors, this is the direction I choose to go right now. But it could be only a matter of time where you might need that vascular surgeon only, right, in the future. So, or you might need that interventional cardiologist who can do both the legs and the heart. But it's really up to you as a patient. But don't close off and just focus on practice. focus on the skill set that is right for your presentation of disease.
Unfortunately, isn't that what the New York Post kind of screwed us on? Is taking the minimal invasive procedures, and they want to just take that away because they said it was too many.
So this is a whole other can of worms. So,
well, okay. That's what it.
And it's the New York Times.
When you said that.
It is the New York Times. So, okay, there is a big debate that's happening, across the country, and it's leading to, and I think Dr. John Phillips referenced this early on in our after show, where he was saying that there are very long delays. He's facing insurance denials on patients that he believes truly do need an intervention or a minimally invasive procedure where they take those wires and balloons into the artery, which I'm going to refer here on out as an endovascular procedure, in this discussion. And because of this New York Times article that came out that seemed to mix two different types of PAD into one. And I had talked, gosh, this is a hard one to talk, kind of mix them up. There's PAD, which is early stage, and then it advances to CLI, critical limb threatening ischemia. Where the New York Times reporter was really coming from was this research that was done by Caitlin Hicks, a vascular surgeon at Johns Hopkins, where she found in her research that there seemed to be a lot of these minimally invasive procedures that are done. In fact, she claims there were too many of these procedures being done in these office-based clinics versus in the hospitals. And she believed that those were leading to a high number of amputations. And that followed with more articles as well with the ProPublica, which is a 501c3 that does some investigative reporting. They ended up finding there were not only a couple of hospital doctors, but also she was claiming that there were some office-based labs that were performing too many of these procedures. And in fact, Medicare was cracking down on some of these offices that might have been using too many of the atherectomy devices, those roto-rooting devices, the plaque removal devices. And Dr. John Phillips even said earlier that there are a handful of these doctors that are in fact doing that. Is that the major problem? He was saying he doesn't believe that that's the case. And there is a large contingency of doctors that don't believe that's the case. But when this New York Times reporter was taking that to a whole other level and saying, well, this doctor out of Michigan, which is treating these advanced stage patients, the CLI patients, the ones that have critical limb threatening ischemia, that this doctor in Michigan was doing too many procedures to save those patients from amputation. And that the state of Michigan had launched an investigation into those procedures. Ultimately, this doctor was not found to have performed too many unnecessary procedures. What they found was this doctor had just lack of documentation, which is a completely different story. But yet, because of that article, insurance companies started pulling coverage from this doctor, and the area hospitals started pulling this doctor's hospital privileges. And ultimately, they sadly went out of business because of that. But it was really, I think, a misunderstanding. And even talking to the researcher that originally started this whole controversy, even that doctor said, I did not intend for my research to be used to support attacking a doctor doing CLI. It was only for those doctors that are performing too many of these procedures in early stage patients, early stage PAD patients, what we call intermittent claudicants, the ones that can walk get a little cramping, but that cramping goes away at rest. Conservative therapy, by society standards, they dictate that, you know, you need to try medication and you need to try lifestyle modifications first, including a walking program. And there are doctors that we know of that are offering procedures for these patients at that stage, which, as I mentioned, if you recall, anytime you have a procedure, it does start the revolving door, that then you're going to need another procedure and you're going to need another procedure, right?
Yes.
I don't know if I've made sense.
Yes, complete sense. I'll tell you something. When I go in and talk to doctors, I always let them know that, you know, I worked in the ER at a medical teaching hospital, and it does change the conversation a lot. So again, knowledge is power. Not everybody is a medical person, but there's no reason why people can't look things up and get educated. So I said, well, you told me that my choices are above knee amputation or live with the pain. And this is after I had talked to you, Kim, and learned about Dr. Arthur Lee. I said, have you ever heard of a doctor named Dr. Arthur Lee? And this is my vascular surgeon now. He kind of gets this smile on his face, subtle, and he says, well, he's done a lot of procedures. And so you hear that from a vascular guy, and my first thought was, oh, this doctor just plunges through the procedure. And I, you know, honestly, I went to see him at that point, Doug, because I was thinking, God, even amputation, I can't live with this pain anymore. And I had an open wound on my great right toe. And since then it's healed, fortunately, because of Dr. Lee. But the thing is, PAD, there's four, oh, I love your puppy, all. There's 4 stages to PAD. There's PAD, and people never show symptoms at all. They go their whole life and never even know they have blockages. Good for them. Then you have claudication, which is pain after you walk to the mailbox and back. After that, you hit the critical ischemia, I think. Mm-hmm. And then the final stage, of course, is acute ischemia, where you're talking, look, emergent amputation here. The patient's going to die from sepsis. And it's important to know these various stages. If you catch it earlier, you have more options. But here's the deal with PAD. It's progressive. It's a lot of it is progressive, whether you get it, you know, from the route from diabetes, or like me, I have really hyperlipidemia and high cholesterol, and the calcium wants to go to my blood instead of my bones. Fortunately, I'm not osteoporotic, but all of these things are intertwined. And it's really important to understand this if you first even wonder if you have PAD, because you go, well, God, what do I do with these symptoms? Well, your answer is simple. Go to the directory and find a doctor about PAD. Save your piggies? Does it hurt when you walk to the mailbox? It's a simple question. Do you have leg pain after walking a distance? Do your legs cramp up? Do you have to stop in the middle of something because your legs hurt? Pay attention. I blew it off for a long time thinking, oh, I'm just getting older, you know. And until walking literally to my mailbox, I had to stop. And my driveway's not that long. So please pay attention, people.
I'm just going to scare the doctor. I'm just going to scare him. I'm going to look at him and go, you don't want me to get Kim on the phone, do you?
Oh, that's great.
I was thinking when Kim was talking, it was like, I remember a couple of times hanging up with Kim and the doctor looking at me and go, who was that? And it was like, that's my patient Art. She helped me remember everything. And he goes, well, damn. He was like,
well,
so now I'm just going to scare him and go, don't make me get Kim on the phone.
Speaking of procedures, again, I found this out from Kim. Dr. Arthur Lee, he's a busy man and he is all about the procedures, and he does use the teamwork approach for having his PAs and other doctors, other nurse practitioners and teams take care of kind of the paperwork end of things so he can concentrate on this rather new technology. And Kim, you were just telling me about a procedure, a DVA, which is really end stage for people looking at like 100% amputation or doing this deep vein arterialization, where they can actually take veins and turn them into arteries and then let the blood flow kind of heal up the area that is necrotic and has turned black, heal it up enough, and then amputate. So there's all sorts of things happening these days. Even, you know, people say too many procedures, and I'm like, well, look, this is a progressive thing. And if someone's looking at amputation and can be saved by doing a DVA and then having a minimal amputation, like just have your toes cut off instead of your whole leg, then why not do it?
Yeah, and I think that that's what I was.
Amputation, you're living with lifelong, probably chronic neuropathy, having device malfunctions, getting it fitted right, the healing time, the callousing of the nub that's left. It's not a fun thing to look forward to at all, even though at one point when I saw this vascular surgeon out of a research hospital of all places telling me, oh, my choices are only amputation or live with the pain. Come on, get real.
We had one of the ladies on the show earlier waited a year for her first one, and she kind of laughed it off. But when it came in, the very first day she was putting it on, she was doing a rubber band, and the very first day it broke.
Yeah, on the prosthetic.
And she goes, "Well, isn't that not how life goes today?"
And I feel like I wanted to clarify, because again, the too many procedures, and I think I was, having trouble finding the caboose to my train of thought earlier, but too many procedures. The real issue that, for example, Caitlin Hicks was really addressing is she thinks there's too many procedures for early stage, or what we call intermittent claudicants. And the real issue that is more widespread right now, leading to the most amputations, are, too many amputations, too many procedures for amputation. But in the New York Times article, they were saying there were too many procedures, such as what Caitlin Hicks was talking about for the early stage, too many procedures for advanced stage doctors. That was what was written in the New York Times article, where they didn't differentiate between early stage and late stage. And so she went and ran with this story using that research that was meant for early stage and applying it to late stage, and saying that these doctors are doing too many procedures in the late stage, where this is what I said in one of my presentations the other day to doctors about this, is for the late stage. I agree that in the early stage, although I haven't seen all of these patients that are supposedly getting offered a procedure in early stage, in a poll we did of hundreds of people, only one person came forward and said they were offered a procedure in this early stage. Most of our patients that come to us and are in our groups actually say that there are too few procedures in late stage, in the debilitating pain stage, right? And what I said to these doctors, I liken literally telling these patients in late stage that there are too many procedures to save a limb, and that shouldn't be the case. Is, would you tell a cancer patient, well, you could do radiation, you could do chemo, it may make you live longer, it may not, but the only guarantee is that the end result will be the same and you're going to die. So why waste our time?
But I've asked this question 100 times. So if I can postpone I know I know my PAD is progressive. I know that. It's just there's no magic cure here. There's no pill I can take and it just goes away. But if I can postpone an amputation for 6 years by having a small procedure done every year, I'd rather do that.
And Anna brings up a good point. She's on watching on YouTube right now. She said it's like the difference between frontal lobotomy versus pinpoint laser surgery. We're still learning. I think Marcia would appreciate that one.
I know some people that need a lobotomy.
That's a whole other show.
Yep. Yeah, we won't get into that one. But so yeah, I mean, and that's part of that insanity that we live with today, in that between the doctors and us and insurance and money and living life and welcome to the journey.
Yeah, I just think that we need to all have a meeting of the minds, and that's why I was really excited to be invited to be a part of the conversation last week with Viva, which is they put on a conference, and many conferences actually each year, one big one. But this one was a select group of vascular leaders. They called it the Vascular Leaders Forum. And we were really talking about how can we all come together, all practices, everyone that has an interest in PAD, every stakeholder that has an interest in PAD, from the federal government clear down to the patient and patient advocates, like we are. And let's bring everybody together and say, you know what, our mission is the same. We want to save life and limb. We want to help improve the quality of life for patients around the world. We want to do this. It's important. So we might have different philosophies, different treatment options, different skills. Let's own that. Let's own who we are and come together and put our egos aside and let's collaborate versus, this continuous crack, of condemnation of other doctors, like Marcia was mentioning, to their faces of patients and competition. It's all at the expense of patients, and all of you are suffering because of it. With doctors going out of business, there are, in an exploding rate. We had Nancy that mentioned in one of the posts, with the exploding rate of P.A.D because of the diabetes epidemic that's out of control. We need as many doctors as possible. We can't just have hospitals that are tapped out. We've got to have these office-based clinics. The more, the merrier. The more that we can get on the front lines of getting these patients in early, the better. But we can't do that if we're not cooperating, if we're not collaborating, if we're competing and we're driving other doctors out of business, and we're tying the hands of doctors, both in the office-based labs and hospitals, such as Dr. John Phillips, who is saying that because of insurance denials, he can't even treat the advanced stage patients that are being woken up every night by rest pain and having to dangle their legs over the side of the bed or get up and pace in order to get some sort of relief to get them through the night.
But in that way,
It's
the
really
insurance
unconscionable.
companies too.
It is the insurance companies. They're the ones that are denying it.
I don't want a gynecologist telling me I can't have a procedure on my toe.
Okay, you're bringing up a whole. You got some cans popping up here. Another can of worms. You bring up another good point, which is that there are insurance companies have go-to doctors to review cases. So when they're looking to review and working on pre-approval for a procedure, for example, they have doctors on hand that will review it. But there have been cases that we've dealt with where we've even seen a pediatric doctor, not even a pediatric vascular specialist, just a general pediatrician, who was denying procedures for patients in Texas, which is very sad. and it should not be the case.
I'd like to add something at this point that might be helpful to being your own patient advocate. With insurance, a lot of them deny the first time. And if you get denied, be proactive about it, pursue it, and demand to know the names of every person that contributed to the report of this denial. You'll be surprised how many times they turn around and approve it right away, because there's even been cases where non-doctors, maybe PAs, maybe some medical background, have denied cases and they don't even know what the heck they're talking about. So again, you got to be your own voice on this stuff.
I think Dr. Phillips that mentioned that one time. He actually called the insurance company and spoke to the person. And afterwards, about officially talking to him, they did approve it. But he said, I had to call and say, wait a minute, what are y'all doing?
Yep. And there was even, I think, Cigna, was it, that is being investigated here in California because it's using bots or an algorithm or AI or something to automatically approve or disprove. Yeah, to approve or disprove. And the doctors who were supervising it just trusted what it said and didn't bother to review any of the cases. And so they found that a lot of the cases actually should not have been disproved. They actually should have gone through, and patients were being denied or delayed treatment for truly conditions that needed timely treatment.
That goes with the pain issue, isn't it? About dealing with the pain issue in the medication. And some people have a pain. I have a high tolerance pain level also, but some people don't. And how, as a doctor, how do you recognize between someone who your pain level is a 6, but mine's a 2, or if I complain about a pain level of 8, and that would kill you because I have a high pain level. I mean, and as a recovering
you have a high
addict,
pain tolerance. Yeah,
as a recovering addict, I don't like taking medication like that. So it's like, but I do remember my pain level going over 11, and it was like I had to take something, but the doctor said, well, you'll be all right, you know. And it was like, well, all right, I guess I have to live.
Yeah, I was sent to, after my vascular surgeon, and I'm pleading with him because I could only sleep like an hour at a time and have to get up and move and rub my foot. It was lying over in bed, I'd wake up rubbing my foot, crying. The pain was that bad. And I have a high tolerance to pain. I think as we get older, and if you've been through a lot of things, pain becomes relative to your own experience, right? Like my toe pain is nothing as bad as, say, gallbladder pain or a horrid toothache, but it's up there. And it's worse than the heart attack I have had. You know, I have a stent in my heart also. And that thing's going strong. My stent was placed in 2010 and it's still good. But yeah, the pain level thing is a subjective test. And so I was sent to this pain specialist, and I walk in and the vibe is like, oh God, we're all a bunch of criminals here. And there's a big sign, make sure you pee in the cup before you leave. And I'm like, Jesus, I went to this place to talk about a DRG procedure, and the PA doesn't even know what I'm talking about. And the doctor that she refers me to only does spinal cord stimulation. Please give me like 18 opioids, Oxycontins, so I can sleep at night. And it's like an act of Congress. Listen, I don't want to do drugs. I drinking is what started all of this problem for me so many years ago. And I quit drinking after my heart attack in 2010. And it's an embarrassing thing for a lot of people to have to go through that. You're already like signaling out, oh, you're here for drugs. It's like, no, I'm not. I'm here to find out about an interventional procedure that will help keep me off the drugs. So that's been part of my experience.
That's true. I remember the first time I saw Dr. Walker, I was up for 2 days because my foot hurt so bad I couldn't sleep. And I thought that was the worst pain I'd ever experienced in my life until my defibrillator went off. And after my defibrillator went off 3 times, it was not, well, let me change. Let me change what I think is the worst pain I've ever felt. And we hear that all the time in the group about people who can't sleep because they hurt so bad, and trying to explain to a doctor that they're not there for drug seeking, but how do we convince that doctor? Give me something to help me sleep at night, or give me something to help sleep for 4 hours. I just need. And let me ask you about pain. I thought about this the other day. Does our pain level and what we go through also depend on our surroundings and what we're going through at that time? So my thought is there are days I'm in a great mood and my graft is hurting, but it's not my number one focus in my head, if that makes sense. There are other days that my graft is hurting and I'm low on money or I'm low on groceries, and it just adds to that insanity thinking. Does that make sense to y'all?
Absolutely. Because, it's not just our physical bodies, it's mind, body, spirit. And like, it's all connected together. And so our mental health is critical in all of this. And, after doing 10 years of caregiving in Dementiaville, after working 7 years in a trauma 1 ER, I've kind of learned how to triage life, and it's become pretty simple to me. I can choose love or I can choose fear. And so, when I'm feeling these feelings of anxiety, I have to stop and ask myself, where is this coming from? Is it really my toe hurting that bad, or am I obsessing on it because maybe I need to go do something else? Maybe I need to go take a walk. Maybe I need to go breathe. Maybe I need to just smile and reach out to someone. Maybe I need to go on a Facebook group and vent. So all of these things are interconnected.
And that's that saying, we keep doing the same things and we keep getting what? Same
That's
behaviors,
the definition
don't
of
we?
insanity, is doing the same thing over and over and expecting a different result.
And that's why
this March, we have to hold hope. We have to, find gratitude in the moment. Yeah, my toe hurts right now. Well, guess what? I'm here in this wonderful group, learning new things. I have a roof overhead. I have food. My puppy dogs are happy. Life is good in this moment. And sometimes I just have to stop and ask myself, like from a old Terminator movie, the waitress, and that's being pursued by the Terminator, and the other girl looks at her and says, well, think about it. Who's going to really give an F in 100 years anyway? I mean, is this really going to matter in 100 years? What's happening right now? It comes back to like right now, this moment.
And we're all curious what Kim is eating. Snacking on. What are you snacking on?
Now that I've dropped my microphone, I am eating. My dad, my lovely, adorable dad, made me a little dish of Granny Smith apple and natural peanut butter.
Yummy,
so
yummy.
Healthy. I'm eating healthy.
And that's why we're all grateful for you, Kim, because you're there when we need you. you've been able to bring us all together. And I also have to remind everybody, I'm not sure how many people here understand what you go through day after day, 24 hours a day, 7 days a week, 365 days a year for us, and how grateful we are that actually you have put your life on hold. Sorry about your dating, but I've told you before, God is preparing that man for you right now, or he's still working on you to get you ready. So just be patient. But you put your life on hold and to be with us, and how grateful we are.
You know, it's so funny because when I started this, I always thought that it would be amazing to find the love of my life, who is a doctor, who is as passionate about limb salvage as I am, that we could literally, you know, collaborate on multiple fronts. We would understand each other. We would understand each other's passion. And we'd be able to travel the world together, and everywhere we go for, let's say, vacation or whatever we do, we could take time to go and help people along the way. You know, and find vulnerable communities that that we can make a difference in. I've always lived a life of service. I come from two parents who believed in living a life of service. And so it only makes sense that this is the direction that I go, that I found my purpose in life. And, you know, I know that there are some people that are not spiritual, that don't believe in God, but for me, my life, my choice, my experience is I believe in God. I have true faith. And for a while, I was floundering a little bit. I was more spiritual than anything else, more just general law of attraction. But God actually came to me and said, this is your life's purpose. This is what you need to be doing. You are my person there on earth to help save life and limb. I need you here. And the moment that I acknowledged that, it just opened the gates to so many people that welcomed, you know, what I had to offer. And I've even had two people in our group who came to me and said that God told them, and both of them are pastors. Both of them said that God led me to you. God said that there was an angel here on earth that is going to guide you in the right direction to save your leg. And in both situations, we were able to save the leg. And that means the world to me. Secondarily, the other confirmation of the direction in doing this was I went to my brother's church down in San Diego. And I was sitting in the back. My brother had given, you know, he was preaching. And so my dad and I had gone just to see my brother. And they have this, I don't know what you call it. Maybe those of you who do attend church more regularly, they had like a prayer tunnel or something like that, where you go through the tunnel and they put their hands on you, and then you get to the end, and you know, one person picks you aside and says an extra prayer for you. And this one woman, Chelsea, pulled me aside, and she puts her hands on me and she says, "Whoa, God really loves you." And I laughed. I said, God loves everyone, right? You tell that to everybody. And she says, "Oh, no, 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 no. Like, you're doing something. What are you doing? God says he loves you." And I was like, come on. And she went into detail, that not into the specifics of PAD, but she went into detail that of how I was somehow helping in healthcare and helping him to facilitate getting people care somehow. And I was like, you talk to my brother. I'm looking for every excuse. And she's like, I didn't even know that you were Todd's sister. Like, I had no idea. And so it just further affirmed that, you know, I really am not only passionate about this myself and love so much and feel so much sense of I don't know the word, of not compassion or empathy, but I feel like you're my brothers, you're my sisters, you're my family. And I am part of your journey. I want to be part of your journey. I want to be with you every single step of the way. I want to remove your pain. I want to find you the solutions. I want to relieve your fear. I want to relieve your anxiety. I want to alleviate that stress. I want to, get rid of the darkness. I know in reality, I can't really do that for everybody and be the end all be all, but that's what I'm trying to do. That's what I want to do. I want to make that difference. I want to be that light. And,
So be
something,
patient.
what?
Be patient.
Yep.
One step at a time, and just believe that you're doing what you're supposed to be doing.
Yep. And it's funny that someone said to me one time, I had an executive coach, Christine Meyer, who's an amazing executive coach. And she helped me through kind of the first couple of years as I was getting used to the roller coaster, of this, because, when you cry, I cry. When you get upset, I get upset. I don't care if you're right, wrong, or indifferent. I don't care. If you're feeling something, I'm feeling it with you. And she said to me, because I was having so many highs and lows all the time, that she said, you can't be sick enough to make someone well, and you can't be sad enough to make someone happy. And I said, well, at least on the latter, I said, at least I can cry with someone and we can just sit in our own little poopy corner together. And sometimes that's what we do, don't we, Douglas? And Marcia, I think, is on. Sometimes we're not just crying to make ourselves feel better. We just cry, right? We just sit in our own little poopy corner just because that's where we are. We know we want to feel better, but you know what? We don't have to do that right now. We can be right where we are because we're together.
He is preparing that doctor, or there's a Toyota mechanic out there that he's preparing for you. So just be patient.
You're so funny. It's amazing. I had one date where I realized that probably it wouldn't behoove me to be in a relationship with someone who's not who's queasy with blood, because there is actually something where I don't know if you've ever done it even with your significant other, or if you remember back dating, if you were dating with phones, but he asked me, this gentleman asked me, he said, okay, here's the deal. This is how we really get to know each other. We switch phones, and the first 5 pictures that come up, you have to explain and tell the story.
Uh-oh. Uh-oh.
Because everyone sends me everything, and I'm not kidding on this. And because one was on WhatsApp, and you can't tell who's who or what's what. All you see, because I don't keep any patient information on my phone, it was just like close-up pictures. Gangrenous toe was one, a leg ulcer was another. The kicker was actually poop that someone had sent me a picture of, because they were on all these medications, and they were wondering if their poop looked normal. And sometimes people, they ask me because they want me to send it to their doctor to ask them, so they send it to me because I'm in real-time discussion. Well, I didn't get a call back from that date again. I did get a good laugh. I didn't know what he saw right away. I didn't know what he saw.
Yeah, he's driving home thinking, what the hell?
Yeah. So anyway, yeah, that was really fun. That was a good one. But yeah, the other thing, I do like, I like learning. I like growing. My life isn't just talking about P.A.D, but you know what? There's still so much to learn, and it is so much of my life right now. I mean, even my dad loves talking about it with me, because I think it's just interesting talking about it. Relates to the whole healthcare system, and health is life. We talk about growing collateral vessels. We talk about eating healthy. It's fun to talk about all of that stuff. It's fun to inspire others. We can't go anywhere, with me and my dad, where my dad's not talking to someone else in his age group about PAD, and about what we do at the Global PAD Association. And, he always talks about Stella. He loves Stella. But it's Douglas's dog. There's Stella. There she is. There's that pretty girl. And that was because we talked about Stella because we were upset that you were kicked out of a facility, Buc-ee's, over in Texas, which I'm actually upset. And but anyone from Buc-ee's sees this, I am still upset that I ended up filing a formal complaint on their website, and I did not get a response from Buc-ee's about your situation and you getting kicked out of Buc-ee's. And there's no phone number to call to be able to get a hold of anyone at Buc-ee's to be able to report it. So they can do anything they want and get away with it, which is very frustrating, because you actually have a real service dog, and we do too. And that's why I think that we took that personally. And my dad keeps talking about Stella and how could they kick Stella out of a facility. But we talk about this all the time. And I think that it's important right now more than ever for everyone to talk about PAD as much as possible to start spreading awareness. They did a study that showed that more than 70% of people, don't know what PAD is. And that's why people are not getting diagnosed. We need to raise awareness, and it's going to take every single one of us. And if it means that, for example, I was on and actually the emergency doctor, I don't know if, no, I don't see him now, but he was on just a little bit earlier when he asked me what I did and I talked to him about PAD, he was interested in it. And I was able to share more information with him, and we started even a discussion, which led to him wanting to join the discussion about PAD right now. And if we can inspire more doctors that we come in contact with to say, hey, join us on a Wednesday, join us on a Saturday, learn more, immerse yourselves with the stories and the experiences of people who are living with it on a daily basis.
Yeah, join me Wednesday night at 6:00. We have a discussion, just an open fire chat discussion about living life today and about PAD and living with PAD. It's just an open. We laugh, we talk, we share.
Yep, we talk about bacon.
Yep.
So, yeah, so I'm married to what I do. I love what I do. I love each and every one of you. And whatever I can do to help, I really try to. And Vlad, we're going to continue to keep working. I do want you to get an appointment with your primary care. And I told you I'm happy to be on the phone with your primary care doctor to have this discussion with you and help to take notes during that discussion so that you can get the answers that you need. Secondarily, what I'm going to do is I'm going to check with biomedics and see if they have one of their primary care physicians that knows a little bit more about PAD who might be in your area. And then you might be able to get a primary care doctor that has more experience with PAD and has their technology. And then you can compare the results between the test you had prior that you're not comfortable with and the results that you may get from using their device as well.
That would be great.
Yeah, I'll definitely do that. Just remind me on Monday to message. Her name is Idara, Idara, and I'll ask her because the PADtest.org is not 100% up yet. We're hoping to have that up completely next week. We're going to do a formal announcement next week that we're doing this. And so hopefully I'll be able to find someone in your area.
So you want me message you on Monday?
Yeah, message me on Monday just to give me a little reminder, give me a little nudge to say, hey, message Idara to see if there's someone in my area
Her name is Idora.
Idara. Her name is Idara.
Idara. I just want to ask, what kind of new test machine the doctor was talking about earlier? Because I joined a little late. He was talking about some new test device, right?
It's called PADnet, PADnet, and it's by Biomedics, BIOMEDIX.com.
And that's the test you was talking about, can be done in my area?
It might be able to be done in your area. I am going to check to see if there is a doctor in your area. I'm on right now, and I'm going to see if they have filled this out. I don't think that they've gotten this out. No, there's nothing. They haven't filled this out yet. So we'll get that populated hopefully sometime next week with more of these. So funny, I just looked up California and it lands on Avocado, California. That's awesome. Love it. Love my avocados. Avocado, California. I was going to share with you guys this, and you might have seen this before. But this is my favorite. If you guys can share this, on your social media, take off your socks. And I said, hey, doc, not dog. So for you dog lovers, I was even going to think of some sort of competition, maybe with people who have well-trained dogs, to actually do this. And we would feature different dogs actually doing this. I don't know if Stella would do it. Douglas, I sent you a picture of Shari doing it, didn't I?
Well, wait a minute.
Oops. Did I stop talking? Can you guys hear me?
Yeah.
Yes, I can hear.
Screen just changed is all. The view changed.
I'll call you. There's my girl.
There we go. So anyway, that was really fun. Just thought you guys would enjoy that. Well, I'm going to jump off. I hope you guys don't mind. It's been really fun to have this conversation. I'm not sure if Douglas is going to stick around, but I have to.
I'll get off too. The thunderstorm's now getting here, so we're probably going to.
You be safe.
Power.
Everyone be safe. And Marcia, if you just shared your story, if you don't mind, if we post that separately, as well, so you can share it with other people who, and we could share it on YouTube, as well as a separate story. But if you'd like to come back in, let's say in June, and we can schedule a Saturday where we can feature you for the entire show. And especially with you being an X-ray tech, I think that you could also have some really great advice, working in the healthcare field for many people.
I would love that. Actually, let me clarify. I'm a retired X-ray tech. I just turned 66 the other day, 2 days ago.
Oh, wow.
And I became an X-ray tech in the time of the transition, right in the middle of from film to digital. And so when I started at this research hospital where the vascular surgeon works, there was still one of those rotating doors for the film, so the dark room would stay dark. And I traversed through film where there really was such a thing as a wet reading, which means read it right away, even though the film's still wet, into now digital teleradiology. It's just amazing, all this technology. But I would love to share my story and my growing passion about PAD. And I'm a big networker. I believe in storytelling. And I believe that our passion from our heart is really pay attention to what you love, because that's a little God wink to you, telling you, hey, pay attention to this because you're good at this, and we need you. We need you to tell your stories and do what you do. And
if you can,
everybody can do. And so with that said, I say keep on walking one step at a time.
if you can join us Wednesday night, join me in my fireside chat and share with us.
Yeah, I will try. Right now, I'm doing this qigong class that
Love it.
is online. It ends at 6, but I can pop in right after. I'd love that.
Yeah,
Well,
anytime, but we'll schedule you for a Saturday and we'll have you share the whole thing and we'll map out the show. And I think that'll be great. Just pick a Saturday in June and we'll definitely
Yeah,
really appreciate you.
I have my calendar right now. I believe in planning ahead to a point.
Oh, that's good.
Let
And we
me
have
see
Anna
all
on
my
there.
doctor appointments. None scheduled so far in June. Actually, no, I do have one in June, but not on Saturdays. So any Saturday, the 15th, in the middle of the month, whenever you want to do it, maybe even any Saturday that month, I'll let you pick because I'm pretty flexible with my schedule. I'm retired now and I can do what I want, when I want, how I want, with whom I want.
Hey, I like that. Freedom.
Yeah,
Freedom.
baby.
you
Yeah.
have
Love
the
it.
same issues I do when I get up in the morning. What am I going to do today?
I get up in the morning and say, thank you. What am I grateful for today? And I go to my happy place. I smile and I do some Tai Chi and Qigong. And it really, listen, exercise, even Qigong and Tai Chi is really good for PAD because you're focusing on circulating your energy. And energy is what circulates your blood.
Yep. It's true. It's good energy. And that's what they actually say. There's some people, we had a woman that came on the show, I think it's susanperformance.com. But Susan Davis it does energy moving. And she talked a lot about that in our early days of, working with our organization. She talked to people in the group about energy blockages can actually present themselves as physical blockages in your body.
Mhm.
And, clearing up those emotional issues that can be energy blocks in your body through doing Tai Chi, Qigong, all of those. There is a school of thought that says it can really help improve your circulation. So different people, different philosophies, right?
Oh, I'd like to add something to that. Being on the board of directors for Elder Options, I got the opportunity to get certified in teaching Tai Chi for arthritis and fall prevention.
Oh,
And
wow.
if people are interested in learning these simple movements, you can reach out to me. I'll answer you back. I can teach Zoom.
Yeah, why don't we
I've
do?
taught locally, and
Oh, you have
actually Qigong
Joshua.
is easier. What's that?
You have Joshua, our producer here, that's salivating, and I can just literally read his mind right now. So why don't we schedule? We should have maybe an exercise day of the week where we get to experience different types of movements, and maybe you wouldn't mind kicking it off, and we'll go, live in the group and live on YouTube, and we'll all get to do it together once a week.
Oh, I love that. Yeah.
Okay.
That actually, that might even be incorporated into, like at the end of my story, a kickoff into, like, let's do Saturdays for exercise, Don't sit and watch TV. Let's get up and move.
Yeah, we can do it any day. You just pick a day and we can go ahead. We can do it. That would be awesome.
That'd be cool.
Cool. Yeah,
Everyone would love it.
I have my living room all set up with my laptop and a different webcam
Okay.
so that you can see my whole body.
Not to put you on the spot, but we'd love to even have something like this regularly. I think that it would be wildly popular. Even if it's, and I know Douglas would do it. I know Marcia would do it. I don't know if Marcia's still on.
Yeah, I
But
am.
I would literally participate every single time.
I would do it.
Yeah,
Yeah,
I'm
Douglas would do it.
thinking Saturday. Saturday is a great day. let's do Saturdays. I'm on board to doing this every week. Part of why I decided to start teaching Tai Chi and Qigong is because it makes me practice. Listen, I live alone and I can be an underachiever and get non-motivated. And so by teaching and interacting with others and providing a service, it keeps me motivated too. The teacher becomes the student.
Yeah.
So let's do Saturdays. I'm all on board for it. I'm not really ready to do it today right now because I'm sitting here actually in my pajamas still.
Is Saturday the only day?
No. Let's see. Wednesdays are a good day. I do some odd jobs on Tuesdays, Thursdays, and Fridays, but even Sunday is good. Mondays are good.
No, the thing about
Wednesday, depending on my doctor schedules, because I have a lot
the thing about Wednesday is we could actually do a short 1 hour gossip fireside chat and go into that right after that because they kind of go together.
Well, I want to do it where we can actually plan an actual separate stream so that it's, you know what I mean?
Yeah.
So that we can schedule it and then people can join from YouTube and in the groups and actually have it scheduled. And I just didn't want to mess with your Wednesdays are for that. And I don't want to interfere with your Wednesdays are the chat days. And that's why I was like, I you know, and then Saturdays we have our show, then we have an after show. So I was trying to figure out if there's another day that we can.
How about a Monday? How about Mondays?
Yeah, start
later
off
on in the afternoon because, you know, I will have some doctor appointments coming up. I swear I see doctors about 6 to 8 times a month right now.
That would be great.
Mondays are pretty open for me. I love this. I'm loving the collaboration.
Me too.
I love it. I love the networking. It builds my passion because listen, I'm an introverted extrovert, which means I can talk to a crowd of 2,000 people, but actually leave me alone. I'm a hermit.
Me
to
too.
recharge my batteries. So I need this interaction to keep my balance.
Yep. I'm with you. And we're here for you. We're open.